Welcome back to the first responder transition. We hope you survived that first quiz just fine and are looking forward to getting into some of the meat and potatoes of this. So the next two sessions that you go through are going to specifically talk about those education topics that were identified in that transition form that we talked about in the last lecture. We're going to talk about some of them in this segment, and in the next segment we'll talk about those things that relate to trauma. So we hope that this is interesting and provides you some good stuff. One of the first things that we're going to talk about is pediatric care. But first of all, I want to tell you guys thank you for doing what you do. I know that you're not, most of you are probably associated either with the volunteer fire department or with a company in where you serve as a first responder. And I want to tell you, as a paramedic, my job is much, much easier and is doable because of the help and the assistance that we get from you guys as first responders. If it weren't for what you do on scene prior to us getting there, a lot of our patients would not have the outcomes, positive outcomes, that they have. So from me to you, thank you very much for doing what you do. Now the first thing we're going to look at is the pediatric assessment triangle. And we're going to look at this because it is, well, number one, it's required, but number two, it is a very, very cool tool. Now, I learned this just a few years ago, and I was so impressed with this because it just breaks that pediatric assessment down into three very easy to remember components and makes that process of doing that assessment quick and effective. Because as we know, our pediatric kiddos don't always appear as sick as they are. And I know you've heard that 100 times. I've heard it 100 times. But the fact is, when you really learn it, is probably going to be with a patient that catches you off guard. Now, I know this because it happened to me, and I'm not going to go into great detail, but I had a 16-year-old son who, very healthy, never been sick a day in his life, big, broad football player, came back from Japan, kind of had a little flu bug thing going on. First, I thought it was jet lag because he was, not sleeping all day and his days and nights were mixed up. Then he spiked a fever. And so I thought, well, he's probably got a little bit of flu bug. And just because I had the resources at my availability, I drew some blood and we checked some labs on him because I thought maybe he had mono. But the only sign and symptom that he had is he was tired and he was breathing just a little faster than he should have been. And then he did start to spike a fever. But he just didn't look that sick. Long story short, a week later, he was going to be placed on a ventilator, and the helicopter had been called to transport him down to Children's Hospital in Omaha, and we darn near lost him that week. He had 3 types of pneumonia in each lung, and in that 2 weeks that he was sick, lost 28 pounds, and I just saw him diminish down to nothing and become very afraid for his life. It's not a pleasant thing to live through. So if this training will help you avoid that or be able to recognize when a child is sick, it's worth every minute we spend doing it. So there's 3 components to this triangle, and this assessment process, all of this is going to happen from the doorway. So before you ever approach this patient, we want to do this quick assessment because you and I both know when you approach a child, the demeanor of that child changes immensely because you're a stranger. They're frightened. They don't know what you're doing there. And so we want to get the best, most clear picture that we can. So that's going to happen for us from the doorway. The first thing we're going to look at is appearance. And we're going to look at that child as far as appearance being How are they positioned? Are they sitting bolt upright? Are they laughing and playing? Are they limp and listless? Are they interacting with their surroundings at all? Are they hanging onto a blanket? Are they laying on the couch? Are they playing in a playpen? Are they responding to their mom? Because sometimes when we walk in, the patient's okay. And then as we start to go up and do our assessment, things change and they start crying and then they don't want to talk to you and you're not getting the real picture. So we want to look at that. Also, we want to look at the surroundings, and that's part of that. What kind of surroundings are they in? If this patient's really sick, is mom holding them, or are they sitting in the middle of the floor? What are the surroundings? Are they warm? Are they cold? Are they clean? Are they dirty? Is the child wanting his mother or wanting his caretaker, or is he not? Is he crying? We just want to look at all of those things. But specifically positioning, that's going to tell you a lot with the child. If you've got a baby that's very limp, that's not a good sign. Babies are balled up and they like to be secure. If you've got a 2-year-old that really doesn't care if you come up to him, that's a problem. So we want to look at that. If they're sitting bolt upright, maybe that's an indication that they're having some trouble breathing. So we want to look at all of that. The next thing we want to look at is work of breathing. And that's the B part of this. A, here's the B. Nobody should have to work to breathe. Now we know that we have some elderly people that have COPD and emphysema and asthma that may have to work to breathe. But a child should not have to work to breathe. So if he's working, that's a concern for us. That's a red flag. So we want to look at those things. We want to look at how he's positioned. We want to look at looking at those substernal markers in the neck. Sometimes when you see a patient that's working really hard, you see those areas between the neck and the shoulders that will suck in as they try and take a breath. We want to look for nasal flaring. Are they holding their chin up trying to get more? Are they tripod positioned? Are they belly breathing and using those accessory muscles? We also, if a patient doesn't have a shirt on, you could look for intercostal muscle use. Now, we talk about that a lot, but I'll be real honest with you. If you're not looking specifically for intercostal muscle use, you won't see it. You have to look for it. And it's those muscles right in between the ribs that get tense to try and help pull the rib cage out to suck more air into that lung space. So we're going to look for all of that. Now my kind of rule of thumb is patients belly breathing, they're not supposed to be. Younger children belly breathe, babies. But if you've got an older child that's belly breathing, he's working to breathe. The higher up you see the accessory muscle use, the harder that patient is working to breathe. So if you've got belly breathing combined with intercostal muscle use, you've got a patient that's working harder yet. If you've got substernal retractions in the neck, a patient's working harder yet. If you combine any of those with nasal flaring, you've got a kid that's working really hard to breathe. So we want to look at that and check that work of breathing. Also listen for sounds that you could hear from where you're at. Oftentimes you can hear stridor. You can hear that croupy seal bark. You can hear wheezing sometimes from across the room. So listen for your sounds. The last thing we want to look at is circulation. Now, from across the room, pretty much that's going to consist of, are they bleeding and what's their skin color? And that'll tell you a lot. If they're bleeding, then we know that their circulation's been compromised and there could be a problem here. If their skin color is poor, such as jaundiced or pale or bright red or cyanotic, gray fingertips and lips, or blue. Those are signs that we've got a problem. So what we're looking for in these 3 areas are red flags. We're going to do that from the door. Okay, so let's look at these kids and tell me, just based on those 3 criteria, are they sick or not sick? So we look at this one. Now this works better if we can have some discussion, but take a second and just look at that picture. And see if you can identify some things to yourself that would be red flags. So first thing you want to look at is appearance. How is he positioned? How's he interacting with his surroundings? What are his surroundings? The next thing you want to look at is breathing, work of breathing. Now obviously we can't hear the sounds on this little guy, but based on what you can see, do you see any indications that he's working hard to breathe? And thirdly, we want to look at circulation for bleeding and skin color. So based on that, on his appearance, and I don't know how old this guy is. I'm guessing 6, 8, 9 months old. But you can see behind his head, the mother's holding his head up. This little guy at this age should be holding his own head up. Okay? He should be more active in this. His arms are just laid out to the side, and he really could care less. Now, looking at his surroundings, he's got cardiac monitors attached to his legs, so my instinct is he's someplace where he's probably not real comfortable. An emergency room, a doctor's office, something. So he should be, oops, sorry here, I have all kinds of issues. He should be a little bit afraid or a little bit apprehensive to be in that condition, and he does not appear to be so. So he's not interacting with his surroundings, and his posture is alarming. So there's a couple big red flags there. If we look at work of breathing, most people say, well, look at his chest, it's all caved in. It does look like he's working hard to breathe, that belly breathing is in place. If you look up at his nose, you can also see that there's some nasal flaring there, and he's got his chin kind of lifted up, trying to get more air in. So I would venture to say there's a really good chance this kid's working to breathe. Another big red flag. And then circulation, we don't see any bleeding. It is difficult from a picture to see what their color is. So, his color may be okay, it may be a little bit pale. But based on this assessment, we've got some red flags. So would you say this kid is sick or not sick? Keep in mind, pediatric patients do not look sick when they are sick. So if we've got 2 or 3 red flags, I think we need to say this kid is very sick. Okay, let's look at this next one. Sick or not sick on him? Now, he's a little bit older. Okay, so we're going to look at appearance. Look at how he's positioned. Look at that appearance. Look to see if you can find anything that would indicate to you he's working to breathe. And then check out the circulation. Some things that I notice with this little guy is the look in his eyes. That look in his eyes is telling me he's anxious, he's afraid, he's looking for some help. That's the first thing that strikes me with him. Then you can see he's kind of positioned, he's got his shoulders back and his chest is straight up. Looks like he's sitting right on the edge of the bed as opposed to laying back on the bed. So I'm thinking his positioning there has me a little bit concerned. I can't really tell if he's working to breathe, but just based on his position, he may be. So I'm going to call this kid sick until I can absolutely prove otherwise, but I'm going to call him sick. Now we're going to look at this little one. Okay, obviously, pictures are only going to tell us so much, but this little, I don't know, let's call it a girl for the sake of difference. appears to be laying down, and she appears to not be very happy with that. She's crying. You can see her legs are kind of flailing. Mom's having to hold on to her. She's fussing and squalling. Is that appropriate for those surroundings? She's got a stranger right there looking at her. Mom's got her laid back, working to breathe. If she's breathing and flailing around. The color there appears to be fine. I don't see any evidence of bleeding. So with this child, sick or not sick, I'm not seeing any red flags with her just based on that patient, that pediatric assessment triangle, or that PAT. So I would say at this point I'm going to venture lean a little more towards not sick until I find out some more information. Then lastly, we're going to look at this one. And my guess is you're looking at that going, holy heck, okay? That PAT has probably run through your head very quickly. And at appearance, you said, oh my gosh, this child is sick. Okay. Just based on this appearance. But let's look at what about the appearance is sending up red flags for you. Now, as a first responder with some experience there, you do a lot of this assessment subconsciously. Let's look at this. What about this appearance? Is this kid positioned normally? Is he interacting with his environment like he should? What's his level of consciousness? Just from looking at this kid, you can see right down here at the bottom, looks like he's got his arm wrapped, which shows me he probably has an IV. He's got a cardiac monitor in place, and we're giving a nebulized breathing treatment. This kid should not be comfortable with this. His arms are just laying there. Look at his eyes. Just those eyes are the eyes of a sick child. He's not looking around. He's not afraid. He's just sick. If you look down here, you can see there's obviously probably some work of breathing. We got some belly breathing stuff going on. Nebulizer treatment probably is another indicator that this kid has got some breathing problems. Look at his skin color. He's just crappy. It's dark circles. Now, obviously, this is a lousy picture. But if we could look at, his nail beds and finger beds and the paleness, I would almost bet you would see at least a pale child. He looks very, very pale from what I can see. And probably some cyanosis, some circumferential cyanosis, fingertips, lips, maybe his ears a little bit. Not only is this child sick, but he's really, really sick. And if I were called to this situation, I would spend about 30 seconds on scene. This kid would be in an ambulance and down the road. As a first responder for you guys, this would probably be indicative of getting a helicopter there if that's appropriate, or at the very least you need to be calling ALS, telling you have a very, very sick child, and get something in the works to get this kid taken care of. Because this is the type of child that could be dead shortly. Okay, so let's look at these two patients, and we're going to talk about the assessment of them and determine, based on the pediatric assessment triangle, are they sick? So here we have a 10-year-old. He has a fever, and he's less responsive, according to Mom. He's got a respiratory rate of 60. He's got a patent airway, but he's using some belly breathing. And you can't get a SAT on him using that pulse oximeter that your medical director said you could use. And he's got a heart rate of 160. He's got pink skin, but he's marbled centrally, so right in the trunk of his body is marbled-looking color. His hands and feet are blue, and you can hardly feel a radial pulse on him. His eyes are open, but he's not making any eye contact with anybody. He doesn't talk to you, and he's just sporadically moving his extremities. based on that patient assessment triangle, is this kid sick or not sick? Well, if you said sick, then kudos to you. Good job. Let's look at this and see what's setting up red flags about this. Now, to know that, I mean, he's got a fever and less responsive. The less responsive is a concern. Fever tells us he probably has an infection going on somewhere, which may or may not be a bad thing. So let's look at his breathing. Okay. Well, let's look at his appearance. So let's look under D for that. Okay. His eyes are open, but he's not making eye contact and he's not talking. Does that tell you he's reacting to his surroundings like he should? No. So there's a red flag. Let's look at work of breathing. Okay. He's got a respiratory rate of 60. Now this poses a problem because how many of us know what the normal respiratory rate for a 10-year-old should be? To be real honest with you, we don't take care of enough pediatric patients to know this stuff right off the top of our head. Now, I'm going to count his respirators and there's 60, but if I don't know if that's acceptable rate or not, I might as well not even count them. So before you guys are paged out to this kiddo, let's get some tools out so we know what normal is. Okay? There's lots of tools out there. If you carry a field guide with you, which some of you do, or you may have one in your truck that you would respond in, those have, and they're just small little flip charts that you carry in your pocket. Those have great resources for knowing what vital signs are normal at different age levels. That would be a great tool. If nothing else, I know a lot of you guys are in volunteer departments and buying all kinds of fancy stuff. This is probably going to happen. There's a it's a wheel, and you dial in their age and it gives you the normals. It's called the PD wheel. I think it runs $25, $30. Awesome tool to have in your jump bag. There's another thing out there called the Braslow tape. It's a very cool tool, but it's very expensive. So if nothing else, just type up a little chart that says, you know, ages 1 to 6 months, this is normal, or 1 day old to 6 months old. 6 months to 1 year, these are the normal vital signs. And take that all the way up to age 18. That's perfectly acceptable. Laminate it, either stick it in your truck, stick it in your jump bag, but you need to have access to this information. So when you're paged out to a 10-year-old, you can look at that and say, okay, this is in my mind, it's fresh. I know what normal is. Therefore, I can understand what is abnormal and recognize when there's a problem with this child. Because if you don't know what normal is, you are absolutely going to miss some key indicators of a child being sick. So I urge you, strongly urge you, to dig into your equipment and see what you have that's going to help you in this area. Because you check this kiddo's respiratory rate, he's got a respiratory rate of 60. Is that normal? No, it's not for a 10-year-old. It's too fast. It's not in the normal range. Okay. He's got a patent airway, that's good. He's belly breathing. Should a 10-year-old be belly breathing? No. The fact that you can't get a set on him, is that concerning? Well, we have to look at some things, you know. Are his hands and feet too cold? Is he in a cold environment? Does he have black fingernail polish on? Okay. But if you should be able to get a SAT on him and you can't, that's concerning. Okay. Heart rate of 160, is that normal? Again, what is normal for a 10-year-old? And if you look at a 10-year-old, 160 is too high. That's not in the normal range. He's got a high heart rate. He's got pink skin. Yay, that's a good thing. So we found two good things here. But marbled centrally, so in the trunk of his body, he's got this splotchy blue, pale splotches. That's not good. Hands and feet are blue. Does that send up a red flag? It should. And then the fact that you cannot palpate a radial pulse on him. What's that telling you about his perfusion, his blood pressure? The fact that his eyes aren't open, he's not looking, and he's not talking, those are all red flags. And the fact that he's moving his extremities sporadically. A 10-year-old should be making purposeful movements. He's not. So I would think, I would hope, we would look at this and say, this 10-year-old is sick. And I would concur. So let's look at this child. We have a 2-week-old. We're called for the child who's fever and less responsive. He's got a respiratory rate of 60, patent airway, belly breathing, and you can't get a sat on this child. He has a heart rate of 160, pink skin but marbled centrally. His hands and feet are blue, and his radial pulse is hard to palpate. His eyes are open. He makes no eye contact. He does not talk, and he moves his extremities sporadically. Kind of sounds familiar, doesn't it? So looking at that, sick child, your gut instinct is to say yes, isn't it? So let's look at it. Respiratory rate of 60. For a 2-week-old, is that normal? If you've got access to a chart, pause this right now and go look at it. If you've got a flip chart or if you've got a textbook handy. If you don't, we'll talk through this. But, for a 2-week-old, a respiratory rate of 60 is normal. He's got a patent airway, that's good. He's belly breathing. That's normal for a 2-week-old, so that's okay. We can't get a sat. Well, have you ever tried to get a pulse ox on a 2-week-old? Next to impossible. So that's probably not as big a deal as it looks like because it's just their little fingers are so tiny. So let's look down. Heart rate of 160. Okay. Again, if we look at our tools that are available, that's normal. It's not a high normal, but it's normal. Pink skin. Marbled centrally. Now, marbled trunk and blue hands and feet. I know you're saying, that isn't normal. I don't care what you say, Cherry, that's not normal. But if you think about it, if you're going to look at that baby's trunk, you have got to take his clothes off. It's a 2-week-old baby. He's going to get cold. If you've ever given a newborn baby a bath, they turn all kinds of colors. Okay? They get spotty, they get blue, they get purple, because they're cold. So if you've got the clothes off looking, and he's got marbled and his hands and feet are blue, may not be a bad thing. That's actually pretty common to happen in a 2-week-old. And a radial pulse is hard to palpate. When you take your CPR class, where do we check a pulse on an infant? It isn't a radial pulse. We check a brachial pulse. And that's because radial pulses are hard to palpate on an infant. So, voila. Okay? His eyes are open. He has no eye contact. He does not talk, and he moves his extremities sporadically. Anything there that's not normal for a 2-week-old. In fact, if they started talking to you, you'd be a little caught off guard. So looking at this, the things that we see that are concerning is the fever. Okay? So really, this child might be a little sick, but he is way less sick than this 10-year-old. And that's really all based on what is normal for that age group. So I encourage you to be proactive. I know it's really easy to say, yeah, I'm going to do something about that, and then let it slip away. Be proactive and take this to your next meeting. If you don't have something in your equipment right now to help you know what's normal for different pediatric ages, get that done. It's really important, okay? Because it makes a difference between life and death with these two. Okay, so some of the steps in the pediatric assessment triangle is that pre-arrival preparation. And that's going to be take the dispatch information that you have and start processing in your head what potentially you could be walking into before you get there. Okay, so what is normal for a 10-year-old? What could cause a 10-year-old to be less responsive? Okay, and start throwing some ideas into a box. Could it be hypoxia? Could it be an allergic reaction? Could it be exposure to chemicals? Could it be a poisoning? Could it be just start throwing stuff into the box so you've kind of got all those thoughts in your head, and then your goal is when you get there to start ruling some of those out. Okay. Then get there, do your scene size up. From the door, you're going to do, well, before you get there, you want to make sure that the scene is safe, obviously, and that you don't need any more help. So based on what you see, if this is an outside event, if it's a traumatic event, right there you may need to make some calls and get some other things implemented. But you need to make sure that the scene is safe for you and safe for the child. Then from the doorway, we're going to do that pediatric assessment triangle. Look at the appearance, work of breathing, and the circulation. And that hopefully is going to help us identify a really sick child from a maybe not so sick child. Not to say that a maybe not so sick isn't sicker than they appear, but then once we've established that initial impression, then we want to go up and do our ABCs. Now remember, with pediatrics, we're going to start at the feet up. Okay, so we're not going to jump right in and start at the head and work down like we do an adult, because we've got to build their trust. And so we're going to start from the feet up. Okay? And allow mom or caretaker to help you, dad, if they're there and they're able to do so. Now sometimes parents are freaked out and they cause more problems than they do good. So it's up to us or our team to help redirect that and get them to a place where we're going to be an asset to the child and not causing more problems. So then do that focused assessment and history, and then keep checking up. Keep checking on those things, because a little kiddo can turn bad quickly. So let's look at this. You're paced out to a 3-year-old with approximately a 20-foot fall from a construction scaffolding. Is that a problem? Oh my. You know, a lot of people in my classes say, what the heck's a 3-year-old doing on 20-foot scaffolding? Well, good question. That's something you need to find out when you get on scene. If there's things like that that are causing you questions, get those answered. So you pull up to a suburban house under construction. Let's talk about being en route here. Okay. What are some things you want to know? What can you do en route to get ready for this call? Okay, we know we have a 3-year-old. We know he fell. So let's think about, number 1, what is normal vital signs for a 3-year-old? Get those out in front of you and keep them there. Secondly, let's think about what are we going to need? Do we need additional help with this? What equipment do we need? Well, for sure, you're going to need a seat collar and a backboard. Okay, probably some oxygen. What kind of backboard are you going to use for a 3-year-old? And what size of seat collar? And where the heck do you keep that in your squad? Okay, or in your truck? We're going to look at You know, if you're going to deliver oxygen to this child, what are you going to use? What kind of injuries might we sustain a 3-year-old from a 20-foot fall? Based on a 3-year-old, we know one thing about kids. Okay? What's the heaviest part on them? Their head. So when this kid falls 20 feet, what is the thing that's probably going to hit first? Probably going to be his noggin. So injury-wise, we're probably looking at a head injury with this kid. Could we have multiple traumatic injuries? Absolutely. Blunt force trauma, maybe penetrating trauma. We could be looking at respiratory issues. We could be looking at multiple broken bones. We could certainly be looking at internal bleeding. So start throwing those things in a box because we may be treating one or more or all of those things. So start thinking about what are we going to do, where are we going to take this patient, do we need additional help? Okay. So as you pull up to a suburban house, Dad frantically leads you to the structure where a small child is sobbing in its mother's arms. Dad points upward and shows that the platform on which the child fell onto a concrete pad. That's one thing we didn't think about. What did he fall onto? Because that makes a difference, doesn't it? Concrete pad, probably not the best option. Does that increase your anxiety a little bit here? Or your pucker factor? It should. Let's look at our patient, our PAT. So from where we're standing now, we see the kid over there. He's in mom's arms. He makes eye contact with you, and he sits up and says, "Go away!" Doesn't want you there. Good or bad? The fact that he's crying and talking, that's a good thing. Okay? 20 feet. So, yay, that's good. Okay? We look at his work of breathing. We don't see any retractions. We don't see any nasal flaring. We don't hear any grunting from him. He's not working to breathe. No red flags there. He's got nice pink skin, and you don't notice any bleeding. Yay. So we did all that, no red flags. So is this patient hurt or not? Big question. Our assessment is telling us this patient's not hurt, but I hope you have something nagging in the back of your mind saying the kid just fell 20 feet onto the concrete. There is a mechanism of injury in place here, and that's a serious mechanism. So I don't think this is a patient we want to walk away from yet. Okay. Right now he's stable. There's still that potential. We've got to consider that. You have to look at the big picture. Okay, so when we do a little more checking here, is the otherwise patent, and I know it said she in a couple places, but this kid's a he in my mind. This patient actively resists cervical immobilization. No way, no how, under any circumstances are you putting on that seat collar. Got a respiratory rate of 48. He's crying, he's got good air entry, and you can't get a SAT on him. He's got a heart rate of 160. He's got a capillary refill of less than 2 seconds and a strong radial pulse. Now somehow you got a blood pressure on him of 110/80. He's alert, he's kicking, he's thrashing around. You do notice an obvious deformity to his left forearm, but the skin's intact over it. And the only other injury you see on him is a little superficial abrasion to his left temple. That's it. Anything there that's got you pennies in a wad? Some things we need to think about is, are we going to put a seat collar on this one? Or shall we manually hold C-spine? Or shall we just let him go? Is he fighting? Is the fighting going to cause more damage than the immobilization is going to gain? He has a respiratory rate of 48. 3-year-old, and he's crying and upset. Maybe not too bad. He's got good air entry. I'm good with that. He can't pick up a sat. Well, heavens no, he's 3 and he's ticked off. You're not going to get one. But the capillary refill is a really good tool to use on kids. And he's got a capillary refill of less than 2 seconds, so that's a good thing. His heart rate's 160, which is a little higher, but not something that I'd be concerned about. I mean, good Lord, he just fell 20 feet onto a concrete pad. And here you are trying to pick on him. Strong radial pulse, so that's a good sign. And he's got a good blood pressure. Now here, if you want to jot this down, is a really good rule of thumb. If you take a patient's age and double it, and then add it to 70. So this guy's 3, we're going to double it, make it 6, and add it to 70. That gives us the number 76. That number is the lowest systolic pressure you'd like to see. So that's the top number. So we'd like to see his systolic pressure be at least 76. Anything less than that, we're going to be highly concerned about. His is 110, so he's good in that area. Okay. ABCDES, kicking, throwing things, not happy. That's exactly how he should be acting. And he's got the deformity to his left forearm. Rarely are those life-threatening. And then that little abrasion. So overall here, are we seeing anything that's raising up red flags with this kid? Now, who would you have called to come help you with this? If you said a helicopter, would you keep the helicopter coming? You said ALS, do you think ALS is still needed? Or would your BLS crew that normally responds with you be enough? Question. You have to keep in mind, though, we still have that mechanism of injury. And we know about kids is they compensate very, very well until they can no longer compensate, and then you're going to see their vital signs go to the toilet. So don't forget that fact, and don't read it and then don't apply it. You have to remember that because it is truly a fact. Okay, are we going to stay or go with this kid? Stay and play? Let's say your BLS crew is there. You can help him get him going. Are you going to do a mobilization? I would. You think this kid needs BLS or does he require ALS? Here's a big question. We're going to take him to a trauma center, community hospital, pediatric hospital. Where are we going to take this little guy? Now, for those of you that are simply first responders and aren't going to take him anywhere, it's a moot point. But think about it in the big picture. Where's the best place for this kid to go? Obviously, it's a traumatic injury. Okay? So a trauma center is going to be better than your community hospital if trauma center is not horribly far away. Okay, we're looking at that 30-minute range. So if we could get him to a trauma center by helicopter in 20 minutes or to a community hospital in 20 minutes, where's the best thing for him to go? Probably trauma hospital. But would a pediatric hospital be better than a trauma hospital? And that's a question for the hospitals. You know, if that pediatric hospital has a trauma team, that's probably the best place for him. If not, maybe the trauma hospital is the best place. Okay, so we have to think about all those things. You have to be proactive because even as a first responder, you're responsible for a lot of this, getting the ball rolling. So when you talk to Mom, really the only thing he's is complaining about is that pain in his left arm and the fact that you keep touching him. He doesn't have any allergies. He's been taking some cold medication because he had a cold and ear infection. He had a burger and fries about 45 minutes ago. Mom and Dad tell you they're meeting with the contractor at the new home site. The child was unobserved for 5 minutes. Parents tell you they witnessed the fall. He cried immediately and had no loss of consciousness. That's good. Now, does the story play out? Well, if the contractor's there, things seem to be fine. If you've ever had a 3-year-old boy and left him unattended for 5 minutes, it's absolutely feasible for him to be on top of that scaffolding in 5 minutes. So, take a look at that story. Is there anything in there that's causing you some concern? If there is, then you need to be contacting somebody. But if this seems like a viable situation, then we still need to keep looking at our kiddo. Okay. So ALS that you called comes, whether that's ground or air or whatever, depending on where you're at. They do a physical exam en route. Okay. They reassessed and monitored his response to treatment. En route, they gave him an IV and some fluid. When he got to the ER, he got sleepy, and so they did a head and abdominal CT. What they found is he had a right skull fracture, he had a liver laceration, and he had an elbow fracture. Okay. The skull fracture and the liver laceration could certainly have been life-ending for him. Okay. He was admitted to a pediatric intensive care unit and was home on day 5. Had you not been proactive to get that treated, could this patient have gone downhill while you were taking care of him on scene and not had this outcome that he had? And the answer to that is yes. So it's really important that we do that very quick, very thorough assessment on our pediatrics, keeping in mind that they are not going to present to us like an adult. Okay. So good job. Hope you got something out of that. We're going to look at one more case here quick, and we're going to look at you're dispatched out to a 34-year-old involved in a farm accident. When you get there, you find a male in the cab of a tractor with his wife, and she's very upset. The wife says that when she brought lunch out, the tractor had already run through the barn wall, and so she went running into the barn, and now her husband won't speak to her. So the husband is in the cab of the tractor. It's intact with no intrusion, really little damage to the tractor. The barn wall was completely penetrated, and the tractor's come to a stop against a combine that's parked in the barn. But lots to consider here. So when you get paged out to this, you want to start throwing things into your box. What could cause this? Okay, now we've got paged out to a farm accident. That doesn't give us very much to go on. But a 34-year-old. 34-year-olds are typically fairly healthy, so that's a good thing to deal with. Now we get here to this. We won't talk to his wife. Okay. We don't know the dynamics that went on before we got there. Is it pissed at her? What's going on here? So let's do an assessment. Okay. We do that quick assessment. He's got a patent airway. He's breathing at 30 times a minute. His lungs are clear, and you're getting 97% saturation when you put your pulse oximeter on. He's got a heart rate of 130. Got good, strong pulses. He's got pale nails and lips, and he's got a blood pressure of 100/66. He's alert. He can respond to your questions by nodding his head, but when he tries to talk, it doesn't make any sense at all. You don't see any bruising, you don't see any deformities, and you don't see any external bleeding. So overall, you think you need additional help with this guy? Think he needs to go be seen? I would think so. Okay. So what else do you want to know from him? Okay. Think about the questions that you would ask him. What other kind of assessment steps would you take with him? What do you want to know from him? What do you want to know from his wife? So we ask him a few more questions. Does he hurt? He shakes his head no. Wife tells you he doesn't have any allergies. She tells you he has no medical history. He's been very healthy. He takes vitamins usually every day. He ate breakfast this morning, ate a good breakfast, seemed to be normal. She doesn't know what happened. She was getting lunch ready, and she heard the crash, came out of the house, and found the tractor in the barn. If you look at him closely, there's only maybe some slight facial drooping on the left side, and then that word soup that he's got going on. Okay. So, look at this. What's your overall assessment? What are you thinking? What are your management priorities with this guy? Where's he need to go? Are you going to get him out of the tractor? ALS or BLS? Who are you going to call to come help you with this scene? Does he need to go by ground ambulance? Does he need to go by helicopter? And that, again, is going to be very dependent on where you're at and what facilities are accessible to you. How sick do you think he is? So with that facial droop and that word soup, I hope stroke came to mind, even though this little incident happened with a 34-year-old male. That certainly does not rule him out from stroke whatsoever. A very good friend of mine who went to high school had a stroke at age 19. So we see that happen frequently. So some things that we can look at for stroke. Okay. Our speech impairment. That can be everything from they can't talk at all to they can't slur, they can't enunciate, to what they say comes out entirely different from what they intended. I don't know if you all remember, but I don't know, maybe a year and a half ago, there was a news reporter for one of the major networks that was doing some reporting, I believe, on the Olympics, if I'm not mistaken. Tall, blonde-haired young gal, and every time she put the mic up to her mouth and it was aired, this weird word ramblings just came out. And you could see the look on her face, and she put the mic down. And then she put the mic back up and tried to say stuff, and just craziness came out. She was enunciating well, but the words made no sense. That's what we call word soup. When they can't get their mouth to do what their brain is thinking. Other signs are dizziness, facial drooping, and to check for facial drooping, we want to say, okay, and I always tell my patients, I said, give me the biggest, cheesiest smile you can give me, and show me lots of teeth. And then look and see if both sides of their mouth, if both eyes are looking the same when they do that. One-sided weakness. Now, I have seen a lot of care providers tell a patient, here, squeeze my fingers. Okay? But they do one hand and then they do the other. If you're going to check for weakness, you need to give the patient your fingers and say, grab both hands and say, at the same time, squeeze my fingers as hard as you can, so that you can judge to see if they're squeezing harder on one side than they are on the other. It's not a matter of can they squeeze, it's a matter of is it equal. Okay? So you want to do that, and on the feet you can have them push against, put your feet on the soles, your hands on the soles of their feet and tell them to push down on your hands and push back, and then hold the top of their foot and tell them to try and pull their foot up towards their nose and see if they're the same there. Watch them walk if they've got an unbalanced gait or they're dragging one foot more than the other. If they're confused, that sudden altered mental status. If they have numbness or weakness in their face, arms, or legs, especially if it's just on one side of the body, that's a sign of symptom of stroke. If they have trouble speaking or trouble understanding. And again, with all these, this is stuff that's new, sudden onset of stuff. Okay? If they're having trouble with their vision in one eye or the other or both. that can be a sign of a stroke. Because you have to understand, parts of the brain operate different things. So there's a part of the brain that's going to operate their speech. There's a part of the brain that's going to operate the muscles in their face. There's a part of the brain that's going to operate their eyesight and their balance and their gross motor movement. So if there's an infarct or a damage to that part of the brain, we're going to see that show up in the body. So loss of balance, trouble walking. And another big sign is that sudden, severe headache. We're not talking like my head kind of hurts. It's like they bury their head in their arms and they cannot tolerate it. They tell you it feels like their head is going to explode. They can't tolerate it. So those are all signs. Now, a stroke is in two forms, and I know you probably had this in your initial training, but it's either a blood clot in a vessel in the brain so that the blood is no longer passed through there, and the cells that are normally fed by that blood vessel are now no longer getting oxygen, so they start to die. The other type of a clot is a vessel that bursts. That's when we see that sudden severe headache. Frequently, that type of a stroke is associated with high blood pressure. And that's what that extra pressure in the vessels causes that to burst. But you will see sometimes all of these symptoms with both of those. So those are the things that we want to check for. One thing that you can do is have a patient stand or sit up, hold both arms straight out in front of them with the palms up, and then tell them to close their eyes and keep their arms out there. When they close their eyes, if one arm starts to drift, then it's, now if they both drift in the same manner, that's not a positive sign. But if one arm starts to drift, or if they can't even hold one arm up, then there's a 74% chance that they've had a stroke. If they've got that sign combined with any other sign, like trouble speaking or facial droop or one-sided weakness, any of that, 85% chance that they're having a stroke. So do those quick little checks to see, and then understand that and communicate that information on to the providers that are coming. So here's some risk factors. We can certainly get this information as well that helps us to identify is this patient at a higher risk for a stroke. Some of those things that put us at high risk are high blood pressure that goes untreated, heart disease, smoking, diabetes, high cholesterol. For women, if women over 40 on birth control pills or women that smoke that are on birth control pills are at a high risk. And the other class of patients, and we don't talk about this a lot, but we really need to be aware of it, are children with sickle cell disease or sickle cell anemia. Now, typically those children are going to be African American and probably know that they have the disease. But that disease causes red blood cells to logjam in their vessels, which can produce stroke-like symptoms and cause a stroke. And so you may see that in infants that have sickle cell disease. And you may see it in young children that have sickle cell disease. They're at a much higher risk for stroke, so we have to keep that in mind as well. So our EMS treatment is to do that pre-hospital stroke assessment and get a really good history. You want to find out, do you smoke? How long have you smoked? Are you on birth control? So we're going to be asking questions we may not normally ask anyway. Check their blood pressure, see what it is. Find out what their normal blood pressure is. Find out if they've been treated for high blood pressure in the past. That'll give you an idea of how long it's been going on. Oxygen is probably not a bad thing. That early detection identifying early when you get there that it's a stroke, so you can communicate that on. And we'll talk in a little bit about what that does when you communicate that early. And then, let the transporting agency and the ER know what's going on so that they can implement some steps they need to implement to give this patient the best chance of recovery possible. So you may hear about the 7 Ds of stroke. I'm just going to tell you what those are. Quickly, we'll talk about them, but here they are. Is detection, dispatch, delivery, door, data, decision, and then the drug. So let's talk about each of those real quickly. Dispatch, as soon as the stroke is in process, those 911 dispatchers are trained to ask the right questions and when they think there's maybe stroke criteria there. A lot of dispatchers are trained EMS providers, so that helps them dispatch the right people. So then the dispatcher detecting the stroke helps to ensure that the right people are dispatched to them. Okay, so we get the type of people that are going to be able to transport. And you'll be a part of that process. A big thing that makes patient outcomes better for these people is that communication from pre-hospital to the hospitals, because our biggest enemy with stroke patients is time. Now, there are medications that can be given, they're called clot busters, that can be given to these patients, but we have a time window frame of 3 hours. So from the last time that patient was known to be normal, we have 3 hours that we can give the medication. Now, we're starting to come up with some medications that can maybe be extended and given longer, but we still try and operate in that 3-hour window. So if the patient went to bed at midnight and woke up at 6 o'clock in the morning and couldn't get out of bed, they are not in that 3-hour window, because the last time they were known to be normal was at midnight, and now it's 6 o'clock. So that window is very short. If you think about, let's say your grandma, okay, starts that morning to have some issues. She drops her coffee cup 3 or 4 times. She cleans it up. She's really struggling hanging on to it, really weak on one side. By the time she kind of gets things cleaned up and drops it the 3rd or 4th time, let's say she's a worrywart, so she kind of acts on this quickly. She calls you because she knows you're a first responder and says, hey, Johnny, I'm having some trouble with my grips here, but I want you to come over and check me out. So you stop everything you do and you go over and check her out, and let's say she's kind of always one of those calling wolves, so you just go on over. Check her out. Yes, indeed, she does have a weakness on one side. So you load her up in your truck and you drive her down to the hospital, and you get there and she goes through the registration process, and they ask her the 25 questions they have to ask her, and she gives them her Medicare card and all of that. Gets checked out. They call the nurse. The nurse comes up. Now let's say it was a 20-minute drive to the hospital. And let's say Grandma messed around with this for an hour before she called you. Let's say 30 minutes before she called you. Took you 20 minutes to get over there. Now have 50 plus 20. We've got 70 minutes into this. And takes you 15 minutes to get back to see the nurse, so we're now at 85 minutes. And then the nurse asks a bunch of questions, and they say, oh, yes, I think we need to do a CT. But it's Sunday, the CT girls aren't there, so they have to call them in. That takes another 20 minutes. And they do the CT, and by the time they get it over, read by a radiologist, and faxed back to them, and get the results back, even though you acted very promptly and nothing inhibited you, we're really knocking at the door of 3 hours when everything went just as smoothly as possible. So delivery, or not delivery, time is really of the essence with these patients. So we want to do is alert ER. So here's the delivery, okay? We get them to the hospital, and they know in advance we're coming in with a possible stroke patient. Number one, so if they have a stroke team, the stroke team's right there waiting for them. Number two, the CT is warmed up and ready, and the staff is ready to do the CT. They already have a physician there that can administer the drugs that need to be given if it's appropriate. So things are in place, lined up, and ready to go. The door, as soon as the ambulance arrives at the door, they're waiting for them. Data. We need to gather up this stuff. Now, we're going to continually be assessing and checking this patient. Give me a cheesy grin. Squeeze my hands. Because if a patient starts to get better, that isn't a stroke. That's what we call a TIA, or a mini stroke. And that'll get better. It has resolved itself. But if they don't, then they stay in running for that clot buster drug, should they be in the time frame for that. So once they get through and ask all the questions and establish what are the risks for giving this drug, they're going to do the CT to make sure that there is actually a clot in the vessel and not a bleed in the brain. Because if they give a clot buster and the brain is bleeding, we've just compounded that problem immensely. So they have to make sure that they meet all the criteria, make that decision, and then give the drug if it's appropriate. So there's a whole process that involves many, many people, and we play a very critical element in getting that ball rolling to give these patients the best chance they have. Okay. So that is the end of session 1. We need you to take the quiz for this. Once you pass with your 84% in 3 attempts, you can move on to that last lecture and the last quiz. Then you can be ready to go. We appreciate it. Hope you learned something, and we'll see you for the last session here shortly.